Hello guys, welcome to our channel. Today we are going to wrap up the expected topics 3. So please do watch expected topics 2 and part 1 also, because we almost covered 100 plus topics and all these are the most important PYTs repeating. So last year also I have done these expected topics, almost 40 topics are repeated from these topics only. So please try to revise and please go through these videos and topics in your notes also. So let's start our session. Before we start the session, those who are new to the channel, please do subscribe and share with your friends. So we will be discussing of the placenta previa and the placenta abruptio. So when I say placenta previa, mostly this will be painless bleeding. Patient will be having the symptoms like painless bleeding and no other symptoms, like doesn't have the abdominal pain or the uterus tenderness, right? And what about the causes? The most common cause for this patient is the history. So previous history of the placenta previa is one of the most common risk factor for the previa development. So there are the 4 types. Type 1, here you can see there is almost more than or 2 centimeters gap between the os and placenta. And in the type 2, it will be less than 2 centimeters and it is also known as a marginal type of the placenta previa. And third one, it almost covered the incomplete os. And fourth one is a complete previa, which will be closing the your os. So which of the following is contraindicated for the vaginal delivery? I can say all types are contraindicated for vaginal delivery. But still, we can try the type 1 for the vaginal delivery, because there is a high chance of the hypovolemic shock, postpartum hemorrhage, or the patient will be landing into death. So to prevent all that, vaginal delivery is not done. So what about the treatment for this patient? So if the patient is more than 28 weeks and patient is stable, means does not have the heavy bleeding and patient is having only the show, and on the uterine ultrasound you have seen one of the type of the placenta previa, what can you do? If the patient is stable, you can follow up with a McAfee regimen. So McAfee regimen is a regular checkups for the mother and also checkup for the baby. So this will lead to, if there is an instability, immediately we can go for the termination. But let's say if even if the baby is having the symptoms like tachycardia, bradycardia, or mother is having the hypovolemic shock symptoms, then if the vitals are unstable, then immediately, regardless whether it is 28 weeks or less than 28 weeks, we can go for the termination of pregnancy. Okay, these are the 2 things that should be done with the placenta previa patient. Next, moving on to the placenta abruptio. In the placenta abruptio, the most common cause will be trauma. Okay, this will be the most common cause of the trauma. Our patient is having the hypertension, diabetes mellitus, and even symptoms, even habits like smoking. This can also cause the placenta abruptio. So what are the symptoms? Usually painful bleeding is seen in this patient. Okay, and also abdominal pain. Along with that, uterine tenderness is seen in this patient, right? These symptoms will be leading to the presentation of the patient. But can we say that the vaginal delivery is not done in this patient? So most of the cases, we are going to prefer the vaginal delivery only. Even if the baby is stillbirth, still we are going to do the expected management with vaginal delivery. And what about the criteria management? So if the mother is more than 34 weeks of gestation, then you can proceed. If she is stable, continue the pregnancy and expect the management. Okay. As per the delivery or the labor pains, you can go for it. And if the 34 weeks or if she is having the severe symptoms, risk of hypertension, eclampsia, or mother is having unstable, then you have to go for the immediate termination of the pregnancy. Okay. This is the first thing that you have to remember. And even if there is a risk of DIC, then also go for the immediate termination of pregnancy, right? This is the abruptio and placenta. Next, moving on to the hypertension in the pregnancy. Let's see what are the types. So the first type is a gestational hypertension. What is mean by the gestational hypertension? Less than 20 weeks of the gestation, and mother is having the 140 by 90 mmHg. Okay, within 4 hours apart. So then we have to consider this gestational hypertension. And another thing is, if she is having the pre-eclampsia, what is the classification of the pre-eclampsia? If the mother is having again 20 weeks of the gestation with more than 140 by 90 mmHg BP, and along with that, she is also having the involvement of proteinuria. So then this condition is known as a pre-eclampsia. And if this is progressed and involves the eclampsia, what is mean by the eclampsia? Mother is having the GTCS. Okay, tonic-clonic seizure is present in the patient. Then this is the severe feature or severe pre-eclampsia. then this is the condition of multi-organ dysfunction is involved. And third type is the chronic hypertension. What is mean by the chronic hypertension? Less than 20 weeks of gestation. That means she might be a pre-hypertensive. Okay, this condition is pre-hypertension, which is the chronic hypertension. Whatever the drug of the choice in this pregnancy patient, what can be given? ACE inhibitors or the herb drugs. These both are contraindicated due to teratogenicity. What can be given? Your alpha drugs can be given and the beta blockers is much preferred. So what is the emergency drug in the patients, those who are with the hypertension with the pregnancy? Then you have to choose the IV labetalol. If the mother is having the asthma, this question is also asked. Then also you have to choose the IV labetalol only. If the mother is having the eclampsia, then what can be chosen? MGSO4. Okay, this drug IV and also IM. These both are given, and this regimen name is known as the Pritchard regimen. Okay, this is the Pritchard regimen given for the MGSO4 immediately to the mother. And not only for the controlling of the seizure, this can be given for the prevention also. What is the protocol for the treatment for this patient? So if you see the mother is more than 34 weeks, then you can go for the delivery. Okay, vaginal delivery is expected. And if it is less than 34 weeks, any of the severe symptoms, then immediately termination. Even if it is eclampsia or if the mother is having the HELP syndrome, then also we are going to go for the delivery immediately. That means termination of the pregnancy is done. About prevention. So for the prevention, what is the drug is given? For the prevention, we can going to give the aspirin tablet daily once of the 75 to 100 mg. Okay, this dose can be given. So this is what hypertension in the pregnancy management. Next one, neonatal resuscitation. In the neonatal resuscitation, first thing you have to see immediately after the birth, check for whether the baby is born more than 38 weeks or not. And if the tone is present, is the baby is crying or not. Crying is very important because this is the first breath that gives the lung compliance, and hypoxia risk is decreased. So if the baby is not having the tone and crying, immediately warm up the baby, stimulate the baby fastly. So if it is still the baby is having the symptoms like no crying or the tone is decreased, then check the heart rate of the baby. If it is less than 100, let's say the 100 beats per minute, what should be done? Start the positive pressure ventilation. Okay, if it is less than 100 beats per minute, start the positive pressure ventilation and give it for the 15 seconds. Again, check the heart rate. If it's still 100 beats per minute, then you have to do whether you are going to proceed to the still positive pressure ventilation if it is responding, or else you can go for the intubation of the baby. That can be done. And after that, if it is decreased, so heart rate is decreasing instead of the improvising, then you have to start the chest compression simultaneously with the positive pressure ventilation. Less than 60 seconds, less than 60 beats per minute, start the chest compressions of the baby. And again check after 1 minute. If it is still less than 60 minutes, now you had to go for the inotropes management. And where this inotropes is given? Through the umbilical cord, you have to give the inotropes. And immediately, if it is still not done, you have to check whether you are doing properly or not. And all the possible risk factors like pneumothorax, congenital diaphragmatic hernia, or any anomalies should be checked thoroughly in this process. So this is what neonatal resuscitation. Any question can be asked. Less than 100, you have to start the positive pressure ventilation. After 15 seconds, check the intubation is needed or not. And if it is less than 60 beats per minute, start the chest compressions. And still not working after 1 minute, go for the inotropes management. Especially what is the common drug? IV epinephrine is used for this baby. Next topic is the milestones. Whenever milestones commonly asked along with the 2 to 3 parts, either gross, fine motor, language, or some of the socials can be asked. So first thing, the gross motor cephalocaudal pathway. What does mean by the cephalocaudal pathway? Here you can see at 3 months, baby is having the neck holding. At 6 months, sit with the support. So first neck, then trunk, then the legs. So like that, the gross motor will be cephalocaudal pattern from the head to toes. Next, at 10 months, stand with the support, and at 12 months, stand without support. Okay, and 15 months, walk without support. 18 months, baby will be climbing, baby will be running. 3 years, 3 and tricycle. 4 years for hopping. Okay, next, fine motor will be 4 months bidextrous grasp, 8 months complete unidextrous grasp, 12 months mature pencil grasp. Okay. Along with that, at 15 months makes 2 cubes, at 3 years draws the circle, and 4 years draws the cross. Okay. Cross. You can remember 4 ends for the cross, and 5 years triangle, and 6 years for the diamond. So these parts can be asked in the examination, should not be missed at least 1 to 2 questions. And language milestones, 3 months coup and 9 months bisyllables, 1 year 1 to 2 words, and 2 years sentences, 3 years recognize the 3 words, name, age, and gender. All right. 4 years tells the story and rhythms. These are the important milestones to be asked. Next one is the SAM criteria. So what is the SAM? This is the severe acute malnutrition. When the baby wait for age, okay, wait for age less than -3 standard deviation, or mid upper arm circumference is less than 11.5 centimeter, or patient is having the edema. Any of one of the following is present, we should consider this baby is having the severe acute malnutrition. One of the most common times, kwashiorkor and marasmus. In the kwashiorkor's baby, you will be having the hepatomegaly and edema is present in this baby. Marasmus patient, only the apathy is seen in these babies. All right. So first, when I see the kwashiorkor baby, these babies are usually protein deficiency. Marasmus is complete protein and calories deficiency. All right. And enlarged fatty liver and poor appetite, severe condition is lethargic condition is associated with the kwashiorkor. Along with that, hypoalbuminemia, and along with that, patient is having a high rate of the infections, dermatitis, and flag sign. This flag sign is also present in the condition of kwashiorkor. Marasmus patient, subcutaneous fat is not present, muscle sarcopenia is seen, edema is absent, severe muscle wasting, voracious appetite is seen. Unless severe condition, because of it is a compensated condition, it is uncompensated condition. Okay, the criteria and difference between the kwashiorkor and marasmus is important. Next, moving on to the IMNCI guidelines. So commonly used in the PHCs, this depends on the patient presentation. So most commonly diarrhea and pneumonia is asked. Let's see difference between the mild, moderate, and severe dehydration. What are the features? At least remember these three. First one, the patient will be normal only. Okay, alert. And next, patient is irritable. This patient will be lethargic. Okay, and whatever the thrust. So coming to the thrust, the baby is normal only. Okay, as usual, if you give the water, they can drink. And these patients are voracious. That means they need immediately very thirsty in this moderate patients. And severe patients, the thrust is not present. Okay, it is decreased. Even if you give the thrust for this patient, there is a high risk due to lethargic aspiration is seen. And urine output is normal, and urine output is decreased, urine output is absent. Okay, one of the following. So if you find any of these things, that could be considered to be the depends on the category of dehydration. What is the treatment? If the patient is landed in the mild one, no, only ORS can be given. And if it is some dehydration, you have to go for the 75 ml per kg ORS. Along with that, rice water, coconut water, breastfeeding should be completed for the moderate dehydration patient. Every 1 episode of the diarrhea should be replaced by the ORS for the baby. And severe dehydration, only IV fluids are given. So how that is IV fluids are given, especially RL or the 5-dextrose should be started for the patient. Less than 1 year, within the 1 hour, 30 ml per kg, or 5 hours should be given 70 ml per kg. And next, more than 1 year, within the 30 minutes, 30 ml per kg, and next 25 hours, 70 ml per kg should be given. So, okay, this can be also asked in the examination. Next, moving on to the IMNCI pneumonia. So, IMNCI pneumonia, if the patient is having only fever, cold, no fast breathing, then this is considered to be the just common cold or common infection, supportive treatment should be given. And if the patient is having the fast breathing or patient is SpO2 is still normal, no danger signs, it is considered to be the pneumonia, and start on the oral amoxiclav antibiotic. And severe pneumonia for this patient, if any of the danger sign, lethargic, vomiting, convulsions, dehydration, all this cyanosis, if the baby is having, then you have to refer to the tertiary care center and give at least 1 dose of the antibiotic for this patient in the PHC. Okay, this is the IMNCI guidelines. So, and also one more question, what is the fast breathing? If it is more than 60 in the less than 2 months babies, okay, if it is more than 50 less than 1 year baby, and if it is more than 40 in more than 2 years, maybe any of this condition is present, that is the fast breathing, should be considered as a risk for the pneumonia. Next topic. This is the retinal occlusion and retinal and vein occlusion. So let's see, this is the first one. This is your artery occlusion. Why? Most of the arteries are occluded. Why, guys? Whether it is MI or whether it is cardiovascular or the cerebrovascular disease. Most common causes atherosclerosis or the C-grade diabetes mellitus is a common conditions. And what should be done? Because this patient will be having the high risk of blindness, irreversible damage to the vascular structure. So treatment will be IV mannitol to decrease the tension and also do the massage. Why massage? Immediately, if you do the massage, this massage can help to dislodge those clots in the atherosclerosis of arterial occlusion. So what is this sign? Specific sign is known as the cherry red spot. Cherry red spot is seen in which conditions? One is your cryo, and about the other ones, trauma, patient is having the trauma or any other conditions like Tay-Sachs disease. These three can be asked in the examination. There are many other diseases also, but at least remember these three. Next one. Here, what is this condition and sign? This is your tomato splash appearance. Okay, tomato splash appearance is seen in which condition, guys? Vein occlusion. Okay, retinal vein occlusion. Why retinal vein? It could be ischemia damage or it could be non-ischemia damage. In the non-ischemia damage, there is completely decreased or the absent blood supply, which will be leading to the iris neovascularization. This iris is going to start the new vascular supply. And if the new vascular supply is ruptured, that will be lead to tomato splash appearance. Okay. And also, these new vascular supply can lead to 100-day glaucoma condition in the patients. And non-ischemia type will be mostly leading to the edema of the veins. And what is the treatment of the choice for this patient? Pan-retinal photocoagulation. Okay, pan-retinal photocoagulation should be done. Right, next one, cataract types and some other features. So first one here you can see the sunflower cataract seen in the Wilson's disease and rosette cataract seen in the traumatic conditions. And here the Christmas tree cataract seen in the myotonic dystrophy, and galactosemia patients will be having the oil drop cataract. And this is reversible condition. And other features of the trauma, not only rosette cataract, patient will be having the hyperemia. Here you can see the blood is accumulated in the anterior chamber, hyperemia. And next one, iridodialysis, your iris will be dislodged and will lead to D-shaped pupil, iridodialysis. Along with that, patient will be also having the vicious ring imprint of the myotic pupils and the lens service. And next one, snowflake cataract seen in the diabetes mellitus patient. Which of the following will be reason? Sorbitol. Okay, due to deposition of sorbitol. Next, due to age or some other conditions, steroid use, uveitis, there will be a risk of nuclear cataract, and these other type, Morgagnian, cortical and intumescent cataracts is formed. Okay, this image-based questions can be also asked. Next, retinal detachment. There are three types of retinal detachment. One is your rhegmatogenous, and other one is second most common, tractional, and third type, very rare, exudative. And what are the causes for this? Rhegmatogenous, most common is myopia, pathological myopia, and tractional, most commonly diabetes mellitus, and fourth one, this is due to melanoma. Okay, choroidal melanoma can be the one of the cause. And rhegmatogenous patients will be having the features like curtain-like appearance. When they have the tear, so that will be leading to curtain-like flouting on the surface. Same with here, curtain-like flouting will be seen, and here also curtain-like flouting will be seen. But what makes the difference of the rhegmatogenous? So they will be also showing the flouters. Along with that, there is a photopsia is present in this patient. Other the patients, they will be not having. And what about the features? So in these features, there will be a tobacco smoke appearance. Okay, tobacco smoke appearance can be seen on the CT scan. Here you will be seeing the features like demarcation lines. Okay, demarcation lines. In the exudative, the name itself telling it is a exudative, so there is a fluid accumulation is seen in this patient. Next, Marcus gun pupil. So Marcus gun pupil is a feature of all three types of tear. Okay, this is also having the Marcus gun pupil. So these are the three different types of the retinal detachment. Next, moving on to the audiology. Audiology, we all know there is a direct questions can be asked. So first type is your otosclerosis. Otosclerosis is a type of conductive hearing loss. So at 2000, so this is known as a Carhart notch at the 2000 heads, and this will be known as your dip. Sudden dip is seen due to Carhart notch otosclerosis condition. And next one is a noise induced hearing loss. This is seen at the 4000 K heads. Okay, 4000 heads, and this is due to which of the following, guys? Sensory neural hearing loss condition. Okay, these two types, Carhart notch at the 2000 and the noise induced hearing loss at the patient of 4000 knots. And other two types also, they like two other types of the sensory neural hearing loss. What are those? So first one is the Meniere's disease. Okay, so Meniere's disease, and second one is the presbycusis. So in this condition, if you do the audiology, Meniere's disease will be uplifting, whereas presbycusis will be low lifting. And how can you differentiate other than that? There is a cochlear damage in the both. So cochlea apex is involved. It will be leading to the uplift when it is compared to the base. And in the basal region of the cochlea, mostly downlift. So this is how you can differentiate between the presbycusis and the Meniere's disease. Okay. Next one, CSF rhinorrhea. So CSF rhinorrhea is most commonly due to traumatic conditions only. Head trauma or patient is having due to cribriform plate disturbance. Okay, cribriform plate fracture that will be leading to the CSF rhinorrhea. What is this sign, guys? This is twice last two exams it is asked. So this is known as your target sign. So also question can be asked, target sign in seen in which condition? It is seen in the traumatic condition only. But is there any other causes of the CSF rhinorrhea? Yes, there are other causes like FES surgery can be happened, or patient is having the simply acquired due to some of the surgeries that can be also caused, right? Or even the tumors overgrowths can be lead to CSF rhinorrhea. But target sign or the halo sign is seen in the only traumatic CSF rhinorrhea. What is the best test that can detect this one? So the best test for this is the beta-2 transferrin. Okay, beta-2 transferrin should be done for the testing the CSF rhinorrhea. Gold standard imaging, that will be HRCT skull. Okay, how about the management? So the management for this patient is just do the supportive treatment only. We don't have to do any surgery, stop it, just it will be closed by its own only. So supportive treatment only done for this patient. Next, vocal cord palsy. Vocal cord palsy is divided into two types, guys. One is bilateral adductor palsy. Okay, bilateral abductor palsy, and here it is bilateral adductor palsy. What does mean by these conditions? So first, we already discussed yesterday that all the muscles, larynx cartilages will be supplied by your recurrent laryngeal nerve, except the circoid muscle, which will be supplied by the superior laryngeal nerve, which is the branch of vagus nerve, right? So what is mean by the bilateral abductor palsy? So abduction is not happening in this patient. Why? The most common cause will be recurrent laryngeal in the thyroidectomy patients. Okay, thyroidectomy patients, the bilateral recurrent laryngeal nerve is disturbed. So what happening here? So all the muscles are supplied by the recurrent laryngeal nerve. So there is no possibility of abduction in this patient. So patient vocal cords will be seen together. Okay, like this. So they cannot go backwards. Okay, only adduction together is seen. So what happens suddenly if the adduction only happening, abduction is not happening? So these patient will be having what happened, guys? Increased respiratory distress. Okay, sudden collapse of the respiratory distress is seen. But how the adduction is at least happening? Because the adduction is due to which nerve? That is due to your superior laryngeal nerve, which is circoid cartilage. Okay, this is. So immediately the treatment should be given for this patient. Intubate or the tracheostomy should be done for this patient. All right, this is the first thing, that is the treatment for the bilateral abductor palsy. Next, moving on to the bilateral adductor palsy. What happened? So adductor, it cannot get to adduct immediately. What is the other one? Abduction, cannot go abduct, but here it not happening the adduction. So here like this, the palsy will be seen. Okay, this gap will be never come together. And what is the risk? This is the most commonly due to your superior laryngeal nerve, or this is due to bilateral vagus nerve injury. Okay, vagus nerve injury that will be leading to the bilateral adductor palsy. Mostly this patient will be having the phonia problems only. So when that together only we can speak, right? But if it is not together, there is a problem of voice. And also if it is always open, there is a high risk of aspiration. Okay, pneumonitis, IRDS can be risk. And what about the treatment? So there are 4 types of the thyroid plasty can be done. So what are those thyroplasties? So type 1 will be for the patients, those who are suffering from the adductor palsy. That is your medialization of the vocal cords. Okay, for this patient, you can get this together, medialization. And type 2 is done for the abductor palsy. You have to do lateralization. Okay, lateralization can be done. Next, type 3 is the shortening. You can decrease. This can be done for the other voice disorder. Type 4 is for the lengthening. Okay, these are the types of vocal cord palsy and thyroplasty surgeries can be done for these patients. Now let's discuss bone tumors. Bone tumors, the most common cause will be malignancy, and that malignancy which will be causing due to metastasis. And what are those metastases, guys? Coming from the prostate or from the breast cancer due to brachial plexus or due to from the venous plexus from the spinal region. So these are the conditions coming from the metastasis to the bone tumors. And other than that, the most common malignant tumor will be multiple myeloma. Okay, this is a condition that will involve the immunoglobulins and also bones. Next, coming to the benign tumors, specific features at least you should know. So osteochondroma is the most common benign tumor which will be seen in the metaphysis of the long bones. And what is the other features? The XT1, XT2 genes are present in this condition. Okay, next one, osteoid osteoma. In the osteoid osteoma, the patient will be having the classical conditions. So when they take the NSAIDs in the night, the pain will be disappeared. So that is what the osteoid osteoma. So on this, you will be seeing the kind of nevus in the bone. That is what osteoid osteoma. Next, osteoblastoma. It involves the vertebrae of that, and these patient will be having the more than 2 centimeters. And this does not respond to the NSAIDs. What is the osteoid osteoma? It will respond to the NSAIDs, but osteoid blastoma is not going to respond for the NSAIDs, right? Next one, giant cell tumor. This is a very recurrent type, involves the epiphysis of the long bones. You often the knee regions is very commonly involved. And the gene that is involved, rank L gene that is involved, and on the X-ray you will be seeing the soap bubble appearance. Okay, this is giant cell tumor. Next, chondroblastoma will be also involving your epiphysis of the long bone, and always the patient will be having the complaints of joint pain. Like you will be misguiding that the patient might be having a metabolic bone disorder. Okay, next one. Coming to the osteosarcoma, the malignant types. In the malignant types, osteosarcoma or the osteogenic sarcoma involves the metaphysis of the long bone. Okay, whereas your benign tumors mostly involves the epiphysis, but this involves the metaphysis of the long bones. Next, what is the other features? You will be seeing the Codman triangle sunburst appearance in the X-ray. Okay, Codman triangle and the sunburst appearance is seen in the X-ray. Next, chondrosarcoma is most commonly seen in the adults, those who are more than 50 years old. And what is the common feature? It will be lytic lesions that is present, and calcifications is also seen. Chondrosarcoma. Next, Ewing sarcoma will be seen in the patients less than 15 years old, and also involves the long bones diaphysis, and the gene that is involved is the translocation 11 and 12, and in the X-ray you will be seeing the onion skin perosteal lesions. Okay, here you can see this is the types of features. Okay, Ewing sarcomas, this is a giant cell tumor, and here you can see the sunburst appearance, and this is the nevus formation, osteoma, and here you can see the Codman triangle. Okay, these are the types of tumors. Next topic, Pemphigus vulgaris and the Pemphigus vulgaris and the Pemphigus foliaceus. In this condition, here you can see the pemphigus vulgaris is the most common, and along with that, pemphigus vulgaris is the most severe one. In this patient, the gene that is involved is the desmoglein 3 and desmoglein 1. And the pemphigus foliaceus, it will involve the desmoglein 1. And whatever the level of the blisters, it will be involving the suprabasal and it involves the subcorneal. And whatever the mucosal involvement, so the pemphigus vulgaris is the most common, involves the oral lesions comparing to the pemphigus foliaceus. And Nichols's scan is positive for both conditions. Histopathology will be showing the tombstone or the suprabasal region. And the acantholysis in the subcorneal region, here you can see the acantholysis that is seen in the oiliaceus. And direct immunofluorescence, you will be seeing the IgG, okay, chicken wire pattern. And the same pattern, but superficially seen in the oiliaceus. Okay, this is one of the difference between the both conditions, pemphigus conditions. Next, coming to the antipsychotics. In the antipsychotics, let's see differences. You will be having the first generation and second generation. So these first generation is known as the atypical, this will be known as your typical. So first generation is your typical drugs. Second generation is the atypical drugs. Why? Because typical drugs is going to block only the D2 channels. But atypical drugs is also going to block the D2 channels and also 5-HT, that is your serotonin channels. And D2 drugs is only important for the positive symptoms. So this will be helpful for both positive and negative symptoms of the patient. So let's see, in the first generation, typical antipsychotics will be having the high risk of extrapyramidal symptoms, whereas this will be decreasing the extrapyramidal symptoms. And metabolically, so metabolic syndrome will be less in the typical drugs and increased in the metabolic of the atypical drugs of the antipsychotics. Examples, you will be having the risperidone, haloperidol, all these drugs will be in the first generation, and your clozapine, olanzapine, zirperidone, all these drugs in the second generation of the drugs. Let's see symptoms. Extrapyramidal symptoms. What does this mean by? So the first one, most common, will be seen the acute dystonia. What is this acute dystonia? Muscle spasms is seen. Usually, when you start these drugs in the hours to days, okay, this side effect will be seen in the patients. What is the drug that you can give? You can give the benzodiazepines to control this symptom. Okay, this is the drug of the choice to control. Next, second symptom is the akathisia. So akathisia, the patient will be having the mostly restlessness, that is the common symptom. And for this patient, the drug of the choice is the beta blocker like propranolol you can give for this patient. Next, third one is the tardive dyskinesia. This tardive dyskinesia usually very late symptom. Okay, patient will be having the late symptom, but very severe symptoms, like patient will be having the sudden movements, jerky movements is seen. For this patient, what we can do, from the first generation drugs, you have to shift this patient to second generation drugs. So please stop this drug and continue this drug. Okay, that is the treatment. Next, the fourth one is the malignant hyperthermia. Okay, malignant hyperthermia, for this patient, we can give the IV dantrolene and stop all the drugs immediately. Okay, IV dantrolene and stop all the drugs. Coming to the metabolic symptoms. In the metabolic symptoms, most commonly, these metabolic symptoms is associated with clonazepine. Okay, clonazepine. And this clonazepine drug will also having the risk factor, the most commonly sialorrhea. Okay, and agranulocytosis. Along with that, patient will be having the seizures. Okay, these are the common symptoms of the clonazepine, and along with that, obesity and the diabetes mellitus risk is high for this patient. And some other drugs and the specific side effects, risperidone will be causing the hyperprolactinemia. Okay, next, QT prolongation is due to ziprasidone. And next, zero weight changes. Okay, so no metabolic symptoms, that is also seen with the zirprasidone. Z for 0, Z for zirprasidone. Next, quetiapine. This quetiapine drug will be having the risk of cataract. Okay. Next, other features like these patients can also develop the QT prolongation, the diarrhea symptoms, and also multiple other extrapyramidal symptoms. And some of the drugs like your clonazepam is recently the WHO has approved that if the patient is having the schizophrenia resistance, then you can give the drug of the choice is the clonazepam. Okay, this is the drug of the choice for this patient. Next, substance abuse. So in the substance abuse, the first one, common one in the world is the alcohol. And for this patient, instead of toxication, you should be reading the withdrawal symptoms when these withdrawal symptoms is coming for this patient. So less than 6 hours, the patient likely to develop the tremors, followed by hallucinations. In the hallucinations, what is the most common one? That is the auditory hallucinations at more than 12 hours of withdrawal, then followed by the seizures more than 24 hours. Then 2 days after, the patient develop the delirium tremens. Okay, this is the how the withdrawal symptoms will be followed in these patients. And what is the treatment of choice for this patient? So if you see the seizures or the delirium tremors, the drug of the choice for this patient is the benzodiazepines. In the benzodiazepines, long-acting drug should be given. What is the long-acting drug? The common drug that we use is the chlorodiazepine. Chlorodiazepoxide. This is the drug. Along with that, thiamine should be given. Okay, this is the treatment. But we need to control this treatment also. In the long term, you have to do the alcohol withdrawal dependence should be decreased by giving the drug disulfiram. Okay, this is one. And other drugs are your like acromposate and baclofen. These drugs also can be given on the long-term dependence. Next, opioids. So how the opioids patients with the toxication will be found? So patient will be having the decreased BP, decreased heart rate, and decreased respiratory rate. So this will be the cause of death. If they are having the respiratory distress, likely to be the respiratory paralysis will be causing the death. Next, pinpoint pupils. Pinpoint pupils, dry mouth. So these are the common features of the opioids. So the drug of the choice for this patient intoxication, naloxone can be given. Next one is the cannabis. The weed, all this will be cannabis. What are the symptoms? Patient will be having the red eyes and increased appetite. Even patient can eat up to 3 kgs also. And also increased heart rate, dry mouth. Okay, so this is the cannabis. Next, cocaine. In the cocaine, patient will be having the high BP, high heart rate. Opposite to the opioids, patient will be having the sweating and dilated pupils. Okay, these are one of the features. And also you might have heard that the Magnon syndrome. Okay, Magnon syndrome. So this Magnon syndrome is commonly associated with the cocaine. Next, tobacco. So tobacco, instead of you will be learning the features, learn what are the treatment that we can give for this patient. Nowadays, nicotine replacement should be done in the sense of spray or nicotine patches, gums. This can be given for the nicotine replacement, or the drugs like you can give the bupropion and also varancillin. Okay, varancillin drug can be given. This varancillin will be having the not only alpha 4 but beta 2 nicotine receptors is present. So it will decrease the tobacco tolerance in the patient. Next, moving on to the anesthesia topics, ASA grading. So grade 1 will be patient healthy, no disease. Okay, grade 2, patient is having the hypertension or some other disease like diabetes mellitus. And patient grade 3 will be hypertension. Along with that, there is a severity is present in this patient. Okay, next grade 4, this patient is likely to be having the threat to life. Threat to life is seen. Next, grade 5. Grade 5 is for the surgery is only choice. Okay, surgery is only choice for this patient. Otherwise, patient will be dying. Next, grade 6. This patient is already on the coma or the brain death stage. Next, antibiotics should be given for at what time? So antibiotics is usually given more 1 hour before surgery. Okay, 1 hour before surgery it should be given. And how about the NBM? So nothing per oral should be maintained for these patients by 8 hours, or best answer will be 6 hours solids, and 5 hours for the semi-solids, and 2 hours for the fluids. Okay, only the water. What I mean by the fluids? Only water. Next, bispectral index. So the bispectral index is done for what? So to see the depth of anesthesia. Okay, this is done to see the depth of anesthesia. Next, neuromuscular monitoring. Why neuromuscular monitoring is done? Is better to see what is the adequacy of anesthesia. What is the location we use? Ulnar nerve is preferable. And this is the ASA grading and some of the features. Next, Mallampati scoring. So Mallampati scoring is to see the intubation. So if you want to do the intubation, you are going to check the Mallampati score. So the grade 1 is complete visualization. This patient is normal and good for ET2. And grade 2 is also better, but only the half of the visualization will be seen. Instead of the soft palate, uvula only is seen in this patient. This can be also done for the ET2. And these two are hard to do the intubation. Why? Because class 3 is only the base of the uvula is present, and class 4 completely not visible of any of the uvula. So that's why this will be hard to do the intubation in the patient comparing to the class 2 and class 1. Next, moving on to the cylinders and their colors. So for the O2, you will be thinking that black and white. Okay, when you wear the black and white, breathing for the oxygen, that will be the black and white cylinder. And the CO2 will be gray color, N2O will be complete blue color, and entonox will be white and blue color. Okay, complete N2O blue color and entonox will be white and blue color. Next, helium will be brown color, N2 will be black color. At least these should be remembered. Next, coming to the O2 therapy. So when I say O2 therapy, there are two types. One is the high flow index and second one is the low flow devices. What does mean by the high flow and the low flow? In the high flow, you will be having the high or the low FiO2. But when it is the high flow index, FiO2 is always fixed. Okay, that is one of the feature. But what are the types? So in the O2 therapy of the low flow devices, first one is the nasal cannula for the mild hypoxemia. What is the feature? It will be only giving the 1 liter to 6 liters per minute, and FiO2 range will be 25%. First one. And if it is moderate, then for the moderate people, we are going to use the simple face mask. And simple face masks will be more than 6 liters, but up to 10 liters limit only. Okay, this is for, but here FiO2 will be 0.60%, sorry, 0.60% only, 0.60% for this patient simple face mask. And third type is the severe condition. For these severe conditions, what we do, we instead of the simple face mask, we are going to use the non-breathable mask. This is your NBM. Okay, non-breathable mask will be more than 10 liters per minute with the FiO2 of 0.90%. In the high flow, we are going to use the Venturi mask. This Venturi mask will be having the more than 15 liters also. So more than 15 liters, and FiO2 is always fixed 0.60%. Okay, this is how O2 therapy can be given. Next one is the BLS. This is the basic life support, how you have to proceed. When you see the patient is having the no breathing, no pulse, immediately you have to start the chest compression. How? In the at least 2 inches depth and minimum 100 beats per minute, you have to start, compress, and allow the complete chest recoil after each compression. Okay. Next, if you see the definite pulse is within the 10 seconds, and if there is no pulse, continue the cycle 30:2. Okay. 30 compressions is to 2 breaths. And followed by, if you see the defibrillator, Let's check the patient is having the shockable rhythm or the not shockable. If it is not shockable, resume the CPR immediately and continue again. And if it is shockable, give the one shock, then resume the CPR. Okay, this BLS is very important. At least you should know one question can be asked in this exam. Next, coming to the adrenal diseases. In the adrenal diseases, we have the two types. One is the Conn's syndrome, other one is the Addison's. So when I say Conn's syndrome, this is due to adenoma. Okay, and Addison's is due to sudden idiopathic or the autoimmune condition or some of the infection. In the adenoma, mostly it will be increasing the aldosterone in the patient. Okay, aldosterone. Aldosterone is involved. It will involve the sodium and it will decrease the potassium. It will cause the metabolic alkalosis. Along with that, it will increase the BP in the patient. Okay, that is what Conn's syndrome. The aldosterone high. Next, Addison's disease, what happens? Completely cortisol, aldosterone, sex steroids will be decreased. So, Na will be decreased, but potassium will be increased. And metabolic acidosis is seen in this patient. And BP is also decreased. Along with that, patient will be having the glycemic ranges deranged and pigmentation is seen due to sex steroids that is decreased. Okay, this is the features of this Conn's syndrome and the Addison's condition. Next, we also have the pheochromocytoma. Pheochromocytoma is a tumor that will follow the 10% rule. It will involve the bilateral in the 10 people and also it will be malignant condition in the 10% of the population, and it can be also extra adrenal in the 10% of the population. But why this condition is caused? Due to the increased catecholamine synthesis will lead to the tumor formation. What is the triad? Common triad that is associated: BP fluctuations and headache, palpitations. This is what's seen in the pheochromocytoma patients. How to cure? You have to follow the ABC rule. Okay, give the alpha drugs, phenoxybenzone, and then go for the beta blockers, then cure the condition. How can you cure? Surgical excision. Okay, this is what protocol for the adrenal diseases. Next one is the lung tumors. So lung tumors, the most common benign one is your pulmonary hamartoma. Okay, pulmonary hamartoma. And what is the X-ray feature? You will be seeing the popcorn calcification. Okay, popcorn calcification. One thing. Next, coming to the malignant, the most common will be again metastasis, and next most common is the squamous cell carcinoma, and second most common is the adenocarcinoma. Third one is the small cell carcinoma. Okay, let's see what are the features. Small cell carcinoma will be involved in the patients, those who are suffering from the smoking, male patients, and adenocarcinoma, non-smokers, and involves the female patients. Small cell, again, males, smokers. Okay, and in this, the worst prognosis will be small cell carcinoma, and this involves the central lungs. Okay, and it involves the peripheral. This will also involve the central lungs. Next, what are the genes involved? P53 gene, and here the EGFR gene is involved, and here LMI gene is involved. Next, paraneoplastic. So paraneoplastic is the common features for here. Increased calcium levels in the squamous cell carcinoma. Here also increased calcium levels and also phlebitis. Okay, phlebitis risk is present in this patient. Lambert-Eaton syndrome is increased, and along with that, SIADH is also increased in this risk of these patients. What about the features? Histology features: keratin pulse. Okay, keratin pulse is seen like this. All keratin pulse is seen in this patient. And here the butterfly. Okay, lipidic pattern is seen. What is meant by the butterfly? The peripheral region, right? Like this. Peripherals and butterfly feature is seen in this patient. Azopardic feature. What is meant by the azopardic feature? So for example, this is the tumor, like this kind of azopardic feature is seen in the small cell lung carcinoma. Next topic, inflammation. Inflammation can be acute inflammation and other type is a chronic inflammation. What are the hallmark features of the acute inflammation? In the acute inflammation, mostly this is due to increased vascular permeability. Whatever the chronic one, in the chronic one, it is due to increased tissue destruction. Okay, this is the main features that should be differentiated between the acute and the chronic type. So in the acute type, what is the features of the inflammation? So firstly, in the acute features, here you can see the first thing is the vasodilatation, mostly due to your histamine only. So this will be leading to the next event, the increased capillary permeability. Then all the events of the marginization, rolling, adhesion, pavementing, and next chemotaxis should be done in the to prevent the inflammation and to further the destruction of the tissue. So this is the normal mechanism in our body. So let's see these events. What are those? So the first one will be vasodilatation. Okay. Followed by increased vascular permeability. Followed by stasis. Okay. Hemostasis is done. So next will be followed by the margination. But these events are completely known as your cellular events. What are those cellular events, guys? First one is the margination. Okay. So the WBC is going to come towards to the peripheral side, and then they will be rolling over. Okay. So rolling over is done on the what we say endothelial cells. Then there will be a adhesion on the endothelial cells. Then there will be pavementing. Okay. Once the pavementing is done, so this is going to be the transmigration. Okay. Transmigration. After that, there will be a chemoattractants, which will be leading to the chemotaxis and followed by the phagocytosis. Okay. This is the event and their mechanism. Here you can see once the vasodilation, vascular permeability, so WBC will be going on to the sides. So this is what rolling over and the adhesions. Once they reach and they go into the tissue side, so there will be a chemotaxis followed by the patient's phagocytosis of the macrophages. This is what events of the inflammation. Next topic, laryngomalacia. We all know that this is the most common laryngeal disorder, congenital in the patients. Okay. So what is the type of the stridor? This is the inspiratory stridor. And how this inspiratory stridor is present in the patient? Usually when the patient is crying, the pitch will also increase. And if the baby is in the prone position, so the inspiratory stridor will be decreased. And what happens when the patient is not treated? Nothing will happen. This can be treated as a supportive only. Okay. By the time of 15 months, 16 months, it will go by itself. And if it is not going, if the patient is having any cosmetic issues, then we can intervene. Until then, it is done normal only. And what is this specific sign is known as, guys? This is known as the omega sign seen in laryngomalacia patients. Next, epiglottitis and croup. Okay, let's see difference between the epiglottitis and croup. So epiglottitis is seen in the 3 years of the children, more than, and this is less than 3 years of children. And most common organism is the streptococcus pneumonia. Here the most common cause is the parainfluenza. Okay, both are stridor only, but more toxic is the epiglottitis. So that's why we need to immediately view the patient intubation and airway savage. And for this patient, the treatment will be nebulization. Okay, like epinephrine, nebulization can be given. Along with that, steroid should be given for this patient and antibiotics for this patient. What are the specific features that is seen? So the thumb sign is seen in the epiglottitis patient and steeple sign is seen in the croup patient, like this steeple sign, and there is a thumb sign seen in the patients. Okay, these are the difference between epiglottitis and croup. Next one is the nasopharyngeal carcinoma. Nasopharyngeal carcinoma is seen in the old age people. And where is the common location, guys? And this is given the image based question also. So the most common location is the fossa of Rosenmuller. And most common cause is Epstein-Barr virus. All right. The most common symptom for this patient, cervical lymphadenopathy. Okay, cervical lymphadenopathy is seen. Along with that, there is a trotter triad is known. What is mean by the trotter triad? Fifth nerve is involved. Along with that, 10th nerve is involved for this patient, and also conductive hearing loss. This is what rotor triad. For the treatment of this patient is chemo radiation is mostly preferred, and then surgical excision can be done. Okay, next one is the facial palsy. So facial palsy is divided into two types, upper motor and the lower motor. So upper motor is only going to involve the contralateral side. Okay, if the lesion is on the this side, but it is going to involve on the opposite side. So this is what contralateral side. And does it involve the forehead? It does not involve the forehead. Okay, it is not going to involve the forehead of the patient. And when it is comes to the lower motor neuron, what are the features? It is going to involve the same side. Okay, same side, that means ipsilateral side, and also involves the forehead. So forehead also involved. What about the cornering of the mouth? So cornering of the mouth is also seen on the same side of the lesion. Okay, that is what difference between the upper motor and the lower motor. Should not make the mistake on this topic. Next one, the features of the mosquitoes and their types. So the first one, common one, Anopheles. This is an endemic of our India. The first Anopheles is commonly caused which disease, guys? This will be causing the malaria. And in this patient, in this mosquito, the features are like inclined position. Here you can see this inclined position is seen. What about the body? The spots are seen on the wings. Okay, like this. The spots are seen on the wings. Next one, Aedes mosquito or the tiger mosquito. Aedes mosquito, commonly, what are the diseases it will cause? It will cause the dengue, and also it is going to cause the yellow fever and chikungunya. These all are caused by the Aedes mosquito. And what are the features? In the Aedes mosquito, there are features like tiger mosquito because of this kind of stripes. These kind of stripes are seen on the body and the legs. That's why, and it is parallel to the ground. Okay, parallel to the ground. This is what Aedes mosquito. Next, Culex mosquito. This will be causing the elephantiasis or Ucarria bancroft disease. Okay, and what about this one? It will be hunchback. Okay, one is elevated, one is on the ground, and other one is the hunchback. And brown color body with the big wings causing the buzzing sound on our ears. This is what Culex. And for the Mansonia, remember like this. If it is not any of these features except, then that will be Mansonia. Next topic is the postpartum hemorrhage. In the postpartum hemorrhage, we should know first how to manage the AMTCL in the last stage of the labor. So according to the AMTCL guidelines, you have to follow the 4 steps. So first step is give the oxytocin immediately in the 3rd stage of the labor within the 1 minute of labor. Okay. Next, the second one is delay the cord clamping. Okay. You should not do fast. Delay the cord clamping of the patient. Next, third one is the controlled contraction. Controlled contraction to prevent the placenta abruptio, retained placenta products in the patient. Next, fourth one is assess the uterine tone. Okay, assess the uterine tone. Not massage, only assess uterine tone. Next, the most common cause overall is the uterine atony. Okay, this is only the one most common cause. First thing, and for this patient, what is the protocol that we should follow? Immediately call for the help. Okay, immediately call for the help and start doing the uterine massage. How to do? So the bimanual uterine massage should be done for this patient uterus to decrease the tone of the uterus. Then what we can do, give the 20 international units of the oxytocin immediately, IM, or if possible, you can go for the methergine drug or carboprost. And last, we can also go for the misoprostol. These drugs can be given for the uterine relaxation. Then if it is still not controlled by the drugs, then we have to intervene with the Buckley balloon catheter. Okay. For this, at least 500 ml water should be filled in this Buckley balloon catheter. Okay, to control the bleeding. Then if it's still not controlled, then go for the surgical options. That is one of the common one. B-Lynch sutures should be done tightly to the uterus. If it is still not controlled, go for the artery embolization. Okay, or artery ligation immediately. Like you can do the uterine artery or also iliac arteries you can do. Then subtotal hysterectomy. If it is still not controlled, there is a high risk patient can die. So to instead of patient dying, at least the uterus can be gone, right? So subtotal hysterectomy is the last choice for the patient. Okay. Next, fungal infections and their features. Here you can see this is the dermatophyte fungi. There are features like in the dermatophyte features like macroconidia. Here you can see this is the spindle shaped and this is the pencil shape. These are the club shapes. Okay, clubbed. These are the macroconida. Whatever the micro, multiple. So there is no microconida, very less, and more microconida is present in the trichophyton, and no complete absent that is seen in the epidermophyton. Okay, next coming to the chromoblastomycosis. So chromoblastomycosis, mostly this will be seen in the former patients, and when you do the when you see the lesion, it looks like cauliflower lesion. Okay, ferocious cauliflower lesions on the lower limbs. For this, if you do the histology, you will be seeing the sclerotic bodies or the copper penny bodies. Okay, copper penny bodies are seen in this condition. Next, other one is the sporotrichosis. Sporotrichosis is due to seen in the former Gardner, right? Rose Gardner. This will be involving the lymphatic route. Lymphatic spread is done. What is the features? The features will be cigar-shaped or the asteroid features on the histology. Okay. Next, moving on to the cryptococcus. So cryptococcus will be containing the capsule. So for this, we are going to use the India ink. And what is the specific feature that can be seen in this cryptococcus? It involves the blood droppings that will be causing the patient severe meningitis in the patients, those who are suffering on the AIDS or the immunodeficiency. The treatment will be amphotericin B plus along with that fluocytosine can be given for this patient. Okay, next, pneumocystitis. So pneumocystitis patients will be having the pink ball appearance. Okay, pink ball appearance. And also pneumocystitis patient, there will be having the infiltrates of the pneumonia. Okay, and if the CD4 cells less than 200, HIV patients are very high at risk for developing the pneumocystitis jirovecii. Next one is the cystic fibrosis. Cystic fibrosis is the autosomal recessive conditions, involves the chromosome 7q. Okay, it involves the chromosome 7q. CFTR gene is involved in this patient. And whatever the test, the gold standard test for this patient is more than 60 milli-equivalents of the sweat chloride test. At least two tests should be positive for this patient to cystic fibrosis diagnosis. What is the features? It involves the lungs, okay, and it involves the pancreas, okay, and along with that, it will also cause the infertility. So whichever the cilia structures, it is going to involve. So the patient will be having the high risk of nasal polyps. Patient will be having the recurrent pneumonia. Patient will be having the indigestion. Okay, and meconium ileus in the first childhood or the congenitally. Okay, all this will be seen. What is the treatment? Supportive treatment should be given for this patient. And the recent development like ivacaftor. So this ivacaftor drug is the CFTR modulators that can be also given for this patient. Next one is the celiac disease. So celiac disease is seen in the more than 6 months of the children. How? Because the celiac disease is seen in the gluten hypersensitivity. Okay, gluten hypersensitivity. What are those gluten drugs? So gluten foods. Remember like this. Okay, bro. What is this? Barley, rye, oats, and wheat. These are the gluten hypersensitivity will be caused in the children. How this is going to presented? Malabsorption. And this malabsorption is going to involve the skin, okay, dermatitis herpetiformis, and also patient will be having the recurrent diarrhea, weight loss, and also iron sufficient even though causing the anemia. Okay, these are the features. And what is the antibodies that is we are going to test? For this patient, we are going to check the anti-TTG IgA. Can be done, or else you can go for the anti-endomysial antibody. This is more specific. And gold standard is your biopsy. Intestinal biopsy is gold standard. Okay, these are the features for this patient. Just avoid the gluten sensitivity treatment. Next, anemias. So anemias are divided into the microcytic, right, macro and normo. These are the three types of anemia. So in the microcytic anemia patients, the mnemonic is Sheetal. What is Sheetal? Sideroblastic anemia, iron deficiency anemia, thalassemia, and anemia of the chronic disease, and lead poisoning. All this will be microcytic anemia. Normocytic, especially liver disease or the kidney disease. Chronic kidney disease or the liver disease is going to cause this. And next, B macrocytic, B9, B12 deficiency and hypothyroidism. Okay, these are some of the anemias. Next, the test can be asked. The direct Coombs test is positive in the autoimmune hemolytic anemia. Whatever the indirect one, guys. So indirect is positive in the Rh negative pregnancy, right? Next, what are the features? So first one is the sideroblastic anemia. Sideroblastic anemia, the most common cause is the allosynthase deficiency, or the patient is having the B6. B6 is deficient in this patient. And what we'll be seeing, the ringed sideroblast is seen in these patients. Okay, this is one of the features. Next one, your hereditary spherocytosis. Okay, hereditary spherocytosis will be having the most commonly, it is going to due to anchoring, but most severe will be spectrum. So what they will be the features? You will be seeing like this. Complete spherocytes is seen on the peripheral blood smear. And next one is the paroxysmal nocturnal hematuria. This is due to CD55 and the CD59. These CD cells are involved due to PIGA gene mutation. In the night times, specifically, there will be a hemolysis. So the features of this triad will be, patient will be having the pancytopenia, thrombosis, and also hemolytic anemia. The gold standard test for this patient is the flow cytometry. Okay, this is one of the features. Next, yesterday we discussed that in the G6PD patients, what is the features that is seen? Hen's bodies and also bite cells, right? These are the C. Next, fifth one, megaloblastic anemia. In the megaloblastic anemia, you will be seeing the basophilic stippling, and also Howell-Jolly bodies. That is seen in the B12 or the B9 deficiency. Next, pernicious anemia. So pernicious anemia mostly post GI surgery due to loss of intrinsic factor and B12. Okay, this is your pernicious anemia. Next, sickle cell. In the sickle cell patients, there will be a sixth position that is transformed with the glutamate. Glutamate G for gone, glutamate is gone, and new one that is came is the valine. Welcome. Okay, so glutamate is gone, valine is came on the sixth position, that is your sickle cell. And sickle cell will be having like these features, right? Due to decreased oxygen. So there is a high risk the patient will be having the crisis. Okay, that is seen. So the drug of the choice for this patient is the hydroxyurea. Next, let's see the iron deficiency anemias and their features. So first, iron deficiency anemia and sideroblastic anemia, and patients those who are suffering from the chronic disease of the anemia. Okay, these features and their iron profile. So iron is here, ferritin, and T percentage. So in the iron deficiency anemia, iron stores are nil, but TABC will be high and T% transferrin is low. And the sideroblastic is opposite to the iron deficiency anemia. So the TABC is only low, remaining all high. Chronic disease of the anemia will be, so iron deficiency will be seen in this patient, but ferritin levels are high only, and TABC is low and T percentage also low. So these can be also easily answered for you guys. Next, thyroid diseases, how to interpret. So we know that primary hypothyroidism, secondary and subclinical. Again, primary hyper, secondary, subclinical. Okay, let's see features. For example, if you take the TSH, T3, T4 for this patient, TSH will be high to compensate in the negative mechanism. But the secondary, almost the both will be low. And again, subclinical, the T3, T4 will be normal. Okay. In this primary hyperthyroidism, TSH will be low due to negative mechanism. Again, in the secondary type, both will be high. Subclinical, always T3, T4. In the subclinical patients, it will be normal only. Okay, next, let's discuss Hashimoto's. This is the most common cause for the hypothyroidism. And it involves the antibodies such as your TG, thyroglobulin, and along with that antiperoxidase. Okay, and how about the Graves' disease? In the Graves' disease, this is the most common for the hyperthyroidism. This will involve the TSH receptors and also iodine receptors. It is going to involve in the patients. Next one is your thyroid cancer. So let's see thyroid cancer, the papillary type. What is the papillary type, guys? This is the most common one, and due to radiation also it can be caused. So the specific features like orphan Annie nuclei is seen in this patient, and what about the metastasis spread by the lymphatic route? Okay, for this the thyroglobulin will be positive as a marker. First one. Second one is the follicular. So the follicular is the second most common, and it is not associated with the radiation. The spread will be hematogenous, and the Hurtl cell risk is seen in this patient. Okay, Hurtl cell, this is the orphan cell. And next one, this is also going to positive for the thyroglobulin. Third one is the medullary, third most common. This is associated with the red gene mutation and also MEN syndromes. And high chance they are going to be the amyloid also. Okay, all this will be risk. For this patient, the calcitonin is the positive marker for the tumor marker for the medullary. And anaplastic is a very rare but very invasive and severe. Okay, rare, invasive and severe condition. These are the thyroid cancer. Next, moving on to the Jones criteria and the Duke's criteria. So Jones criteria is subdivided into the low risk and the high risk. But remember, at least one should be maintained. The high risk condition, especially in the Indian families. So high risk will be involving the polyarthritis of the patient, along with that monopolyarthralgia or the fever ESR. What is the criteria that should be maintained? So major criteria, we all know that patient will be having the carditis, chorea, erythema marginatum, and the subcutaneous nodule. Next, what is the minimum criteria should be followed? So first, at least 2 major or 1 major plus the 2 minor should be maintained. Along with that, we also need the essential criteria. Group A positive beta of the AS4 titer should be also seen in this patient. First thing. Next, Duke's criteria. Major criteria will be involving the blood culture only. So typically, at least 2 separate blood culture should be positive, or microorganisms of the infective endocarditis positive cultures at least 2 different 12 hours apart, or at least 3-4 hours apart should be get for the positivity, or single titer should be positive for the Coxiella Bernati like features. And along with the blood cultures, you should be having the endocardial involvement that should be positive for the echocardiography. Whatever that oscillating feature on the mass or the abscesses, new prosthetic wall dehiscence, anything that should be positive on the echocardiography. So culture, echocardiography, positive in the major criteria. In the minor criteria, fever, vascular phenomena, immunological phenomena are the positive culture. That is not criteria of the major. Okay, whatever major positive is done, but in the if it is not belongs to the major criteria, that should be positive in the minor criteria. For this also you need the 2 major, okay, or 5 minor, or at least 1 major, 2 minor. That should be positive for these patients. Okay. Next, migraine is the second most common of the headache. What is the features? Usually the patient will be having the classical or the non-classical. The most common type is the non-classical, seen in the females, and the patient will be having the 72 hours of headache. And how? Unilateral pulsatile headache, right? One of the features. And in the classical type, there will be aura is present. And in this aura, photophobia is present in these patients. Along with that, nausea or vomiting. Non-classical, no aura. That is the feature of the non-classical. Okay. What is the treatment, guys? So first line and drug of the choice. So first line, NSAIDs is given. The drug of the choice is the triptans. Okay. Sumatriptan is one of the drugs. And prevention. Prevent by giving the beta blockers. Drug of the choice is the propranolol. Okay, or topiramate, verapamil, botulinum toxin, and amitriptyline. Okay, these are the drugs that can be given for this migraine patients. This is the logo of World Health Organization. This logo is belongs to the UNICEF, and this is for the leprosy. Okay, this is for the leprosy, and this is for the IDDCP, and next one is for the National Health Mission, and this is for the vector-borne diseases. This is for the eye vision, and this is for the women and child development. This is for the TB DOTS program that will be given in the PHCs, and this is for the pulse polio for all the children, school age children. And next one is the anemia prophylaxis. The World Bank logo, this belongs to the Ministry of the Health and Women Welfare. And this is for the Pradhan Mantri Jan Dhan Yojana. This is for the ICDC program, which will be in the Anganwadi centers. And this is the Kata thermometer, and this is the globe thermometer, and this is the fling thermometer. Okay. Next, here you can see other logos. This is for the AIDS control patients, National Health Insurance Policy, immunization under the one umbrella, biohazard waste, red collection bags. And here you can see this is the Universal Immunization Program logo. Anti-tobacco that will be on the 31st May. No smoking day on the 2nd March. And occupation hazards, cold health chain management, IUCD, and DMPA drug, vaginal ring, diaphragm. And vitamin A prophylaxis, leprosy day on the Jan 30th. And next one, here you can see. This is the logo for the Suman, for the pregnancy women. And this is the logo for the National Tuberculosis Elimination Program. Here you can see this is the MENA for the child development, and this is the SAPNA for the leprosy. Okay, this is Janani Suraksha Yojana Karakyama for the deliveries of the babies. Next, National Program for the Non-Communicable Diseases. This is the midday meal. And this is known as the Lippi's loop. Laksha for the labor. Okay, next. This is the histogram, bar chart, and component bar chart, multiple bar chart. And this is the pie chart. Image-based questions can be asked from these images. So here ends our part 3, guys. And thank you for everyone for joining with this video's rapid revisions. Hopefully, this is going to help you in the examination. All the best, everyone. Please do prepare well and practice well and do well in your examination. You are all going to crack this examination. So don't forget to subscribe and share with your friends.